So today I'm going to talk about mainly one of the treatment studies that we completed recently, and it is in the public domain, and you can check um, more of details afterwards. So the treatment survey, as many of the folks on the call probably know, is initiated by Martha Ecke, who is a ME/CFS patient and a researcher. She initiated this study and single-handedly conducted a survey. We had really, we were really fortunate to have the opportunity to work with her. And I just want to show my highest respect to her dedication to patient-led research. And in addition, more than 5,000 patients with ME/CFS and long COVID participated in this study, for whom I'm extremely grateful. As I mentioned, the paper is already out and it's publicly accessible. The survey included questions on patient symptoms and comorbidities, as well as the self-reported effects of over 150 treatments that Martha collected from the clinical guidelines of treatments, as well as patient response in social media. And the questions asked patients in terms of the treatment effect on their overall health, as well as individual symptoms. In addition, dose and duration information of these treatments are typically collected. The survey is still available. The current survey has already completed, but the survey itself is still available on SurveyMonkey if anybody is interested in check them out. More than 3,900 patients whom the response were analyzed because they passed quality control. As folks might already know, the survey itself is quite comprehensive, and not every patient was able to complete the survey. And Peng Li in my group analyzed the data. So this is just a very brief summary of the categories of the treatments from many different supplements, for example, amino acids, vitamins, antioxidants, supplements from green or black tea, from mushrooms, and mitochondrial enhancers, omega-3 fatty acids, and many other selected supplements that patients told us that they use, or they tested for their symptoms. And I should say that the non-pharmaceutical approaches turned out to be very effective among the positive response that you're going to show in, you're going to see in a few slides, and that includes pacing and fluids, and along with other treatments. In terms of pharmaceutical treatments or drugs, we have antimicrobials, the antibiotics, antivirals, and other antimicrobials such as hydroxychloroquine and others. The hormone replacement therapies, which some of patients on the call probably are familiar with, the MCAS treatments that Dr. Yemen discussed already. The neuropsychiatric medications, which include ADHD treatments, antidepressants, and other categories. The cardiovascular medications, for example, the beta-adrenergic receptor inhibitors, and calcium channel blockers, and a few other cardiovascular medications. The treatments on POTS, which Dr. Systrom already described to a large extent, for example, mastino, and selected treatments of long COVID drugs, for example, Paxlovid and metformin. The treatments of ME/CFS, for example, low-dose naltrexone, and IVIG or sub-Q IG. And here's sort of a more detailed list of those 150 treatments. The detailed list is available as the supplementary data set of that publication. Yeah, everybody can take a look at the treatments that they might be interested in seeing there. So let me just very briefly describe the patient demographic and clinical information that we saw from the survey. So between long COVID patients and ME/CFS patients, as you can see in the top panels, between females and males, we typically get roughly 70 to 80% of females, 20% also of males, which is known in this field. There's not really a difference between gender distribution, and there's no difference between age distribution, as you can see in the bottom as well. So patients of ME/CFS and long COVID who participated in this survey, their gender and age distributions are very similar. In terms of their disease duration, as expected, the long COVID patients have on average more than 10 years of this disease, while long COVID patients have on average 1.5, 1.6 years. The patient capacity levels, the ME/CFS patients, unfortunately, are in general more sicker than the long COVID patients. So they're mostly from moderate to severe to very severe in the ME/CFS group. In terms of the most troubling symptoms, as you can see in this side-by-side bar graph, on the left side are ME/CFS symptoms percentage. Right part is the long COVID symptom percentage. They match each other very well. The most troubling symptoms, as we all know, are fatigue, PM, brain fog, and sleep problems. So now I'm going to talk about the results that we analyzed. Shown here are the top 20 most effective treatments that we received from the patient response. Vitamin C, the oral version, is used as the baseline control. And I also listed graded exercise therapy, which patients overwhelmingly responded that it affect negatively on their health. So I'm going to, in the next couple of slides, talk more into each one of these top 20 treatments, from fluids, electrolytes to curcumin, that's ranked based on one, number of patients used this treatment, and two, their response. So as we probably already expect that, if there are more patients that use a particular treatment, then there's more statistical power for us to say that this treatment is statistically significant in improving patient conditions. The second part is there's always a subset of patients that would respond positively to a particular treatment, for example, fluids and electrolytes, from much better, moderately better to slightly better. But then on the other side, there's typically a small percentage of patients that would report that the treatment make them either slightly worse, modestly worse, or much worse. An example would be ADHD stimulants, as you can see here. As I mentioned, we also surveyed for each one of these treatments, what are the symptoms that the treatment would improve. So as you can see here, for example, fluids and electrolytes, pouts would be the most effective symptoms that, according to participants, that would most improve. While the second is pacing, where you would have fatigue, PM, and brain fog, that patients report pacing would most likely help them. And as expected, compression stockings would mostly help pouts, for example. And as Dr. Strom already mentioned, in the LIFT trial, low-dose nitazoxanide and mestinon are among the top 20 treatments that the patients indeed reported that helped them. Interestingly, if you look at the individual symptoms, that each one of these treatments help, low-dose nitazoxanide seem to help fatigue, PM, and brain fog, but it doesn't seem to help pouts specifically, while mestinon specifically help symptom of pouts. So by combining these two, we hope that this synergy would help patients to resolve their symptoms. So now I'm going to talk a little bit more into each one of these 20 treatments. I sort of characterize them based on bigger categories, so we can talk a little bit easier of their response. So the first one is the non-pharmaceutical pharmacological approaches, which include fluids pacing, compression stockings, as well as the lymphatic drainage and vagus nerve stimulation. They all seem to significantly, according to patients, help their symptoms. And as I mentioned earlier, each one of the treatments seem to help different symptoms at different level. So perhaps physicians and patients can start thinking about treating, taking different approaches based on their symptom profiles. The second class, as Dr. Yaman already mentioned, are the MCAS treatments that includes antihistamines and other mast cell activation treatments. For example, as Dr. Yaman mentioned, the mast cell stabilizers and antibody treatments, for example, Xolair. So what we found was that in antihistamines, there's a particular combo that seems to work significantly better, again, according to patient's response to other antihistamines, and that is H1, H2 inhibitor combo. And melatonin, as we know, as we expect, mostly help the sleep problems in patients. And it's one of the only ones that significantly help the patients in terms of sleep problems. There are a range of supplements, as I mentioned in the beginning. These are the 4 categories that seem to have patients respond significantly better than the control, which is vitamin C. And we analyzed each one of the subcategories to see whether there's a particular type of supplement that would respond better than the rest. And that those are listed here, namely for B12, the injection version works better than other versions. For CoQ10, the dosing above 100 milligram per day outperform vitamin C and get even higher positive responses with higher than 200 milligram per day. For PEA, the enhanced bioavailability version outperform the rest. Now I'm going to move toward the drugs. So we already talked about LDN and mastino. Between beta blockers or ivabradine, ivabradine significantly outperform beta blockers. What the patients responded was that it mostly helped their POTS symptom. The ADHD stimulants significantly helped patients fatigue and brain fog, but not PM and POTS and sleep. And what we found was, for example, Adderall and similar ADHD stimulants significantly perform better than SSRIs, SNRIs, and other antidepressants. In fact, none of the antidepressants actually showed overall a positive effect on patients. A word of caution for all the ADHD stimulants as well as antidepressants. For each one of them, there's a significant minor group of patients that responded negatively, and the minimum was more than 20%. For IVIG, sub-Q IG, it seems to overall improve quite a few symptoms other than sleep. And for the anticoagulants and antiplatelets, it also seemed to help the patients. One of the versions that, as we know, is available, as a supplement is this nattokinase, lumbral kinase. As a scientist, when we looked at the available evidence, we saw that there's animal studies where nattokinase and lumbral kinase that seem to help the degradation of microclots, but I'm not at this moment seeing sufficient human studies showing that it indeed worked in this particular way in human. But on the other hand, there's significant number of patients that have taken this group of supplements, and the overall response seemed to be positive. So it's one of those things that perhaps requires further studies. As I already mentioned previously, there is this group of negative treatments that affect central nervous system, and there's a significant minor percentage of patients that report that these treatments negatively affect their overall condition, which are listed here. Obviously, graded exercise therapy is overwhelmingly detrimental as reported by patients to their health. So we next compared the treatments reported by patients of ME/CFS and long COVID. So the x-axis is the response of ME/CFS patients, y-axis is the response of long COVID patients of each one of the 150 also treatments. Very few of them showed significant difference between these two groups. We then tried to subcluster patients based on their symptom profile and comorbidities. So the top part is symptom profile. The bottom part is the comorbidity profile. And we were able to subgroup patients into 4 groups. The first group, which is group 1, has most percentage of symptoms. So you can see they're in generally darker than the other 3 groups. The second group has mostly pulse or orthostatic intolerance. The third group, as you can see here and here, do not seem to have pulse, but they have higher rates of brain fog, sleep problems, and pain. We get a fourth group where the symptom burden seems to be a little bit lower than the other 3 groups. And when we looked at the treatment response in each one of these 4 groups, we can see distinct treatment response for some of those treatments between these 4 groups. As an example, if we use ADHD stimulants, it seems to significantly work better on the third group where patients do not seem to have been bothered by pulse or orthostatic intolerance. So that gives us hope that perhaps by combining patient responses together with, for example, electronic health records and expert expertise in medicine, just as example, Dr. Yeoman described a few minutes ago, perhaps we can eventually be able to build a system that can predict which treatments might be able to help which subclass of patients. So there's obvious limitations of this study. Mostly this is a patient survey. It's non-blinded, it's open label, and there are multiple factors can potentially affect patient response. Randomized control trials obviously are the gold standard to verify these responses. Like to summarize the findings, what we found was that the ME/CFS patients and long COVID patients, in terms of participating in this survey, they appear to share very similar symptoms as well as treatment response. What we saw was that the treatments responded by patients as beneficial are largely consistent with the consensus guidelines set up by ME/CFS physicians. I listed 2 down here, which probably can help patients and their physicians to choose treatments that might be able to benefit them based on their symptoms and their comorbidities. Because as we saw, most treatments have different effects on different symptoms. Again, just a word of caution, several classes of drugs, for example, the drugs that affect central nervous system seem to all have over 20% of patients responded negatively. So it probably would require physicians' intervention to try some of these treatments. In terms of next steps, as I already discussed, we're trying to combine information from this particular study with the patient electronic health records and other information to see whether we can better predict patient treatment outcomes from their symptom profiles and comorbidities. And we're thinking about conducting the next round of surveys, especially targeting on some of those treatments that seem to be showing promising results, and also other ones that, as for example, Xolair, as I show here, there are only 11 patients that responded so far. Obviously, it's an expensive treatment, but if we just based on this very small data set, it seemed to significantly help a large percentage of patients. And again, Dr. Yang already discussed some of this with respect to MCAS. For the next few minutes, I'm just going to briefly discuss another reason, another motivation why we did this study. That is not only to help patients to see what are the existing treatments that might be useful, but also try to see whether we can use this information in combination with a lot of the information that other researchers have already discussed today, this morning, as well as the past 3 days. That is typically on the disease mechanisms, from literature, from individual basic research, and combine that with data from patient surveys and clinical trials, electronic health records. So we use a particular approach to do that. That is to basically bring everything together into a so-called knowledge graph, and then you can use these days, AI-based network models, for example, graph neural net models and large language models, to model the disease and potentially be able to identify the treatments that people haven't been able to identify them in the past, and perhaps can help us to prioritize what are the treatments that we would like to try. As shown here, what we did was basically we compared the information in the literature and on MCFS and long COVID, and compared that with the vast amount of information, as we all know, in terms of genes, compounds, disease, drug effects of other diseases, and ask the question at each level, from what we know at gene level, what would be other diseases that share the same signature? At symptoms level, what are other diseases that would give us a symptom like, for example, fatigue or sleep problems or POTS? And can we bring all this information together and identify some of these molecular mechanisms as the treatments? And then we use that information to come up with a hypothesis, and then ask the question, can we actually find corroborating information from the survey results? If the drug is actually targeting one particular pathway, whether we can see an indication that patients would respond positively if we were to activate or inhibit that pathway. This is not ready for a detailed discussion. So I'm just basically talk about where we're thinking at this moment. In particular, we looked at the metabolism system, and the reason is we have this opportunity to work with Dr. Systrom on the metabolism side, so we can actually look at for example, signal from a patient muscle while they were exercising. So this is just one example of a paper we recently published where we analyzed the muscle biopsy of 2 recent publications on MCFS and long COVID, and were able to, using this approach I just briefly described, to identify in the metabolic network what are the problems that we see in the muscle. And then we do this in silico simulation to ask the question, if we were to give some of these endogenous metabolites to supplement the endogenous metabolites, can we predict which ones would actually help releasing these type of symptoms. So what we saw here in the muscle is mostly a reduction of getting amino acids into the TCA cycle because of the problems that quite a few speakers have already talked about this morning in the TCA cycle. So we predicted that this L-ornithine, L-aspartate LOLA could potentially compensate for some of these problems in the muscle. After the paper was published, I received a number of responses from patients. What made me happy was at least so far the majority of patients responded positively. For a few patients, according to them, they were able to get their life back. That's really good to hear. But I have to say, there is a percentage of patients that told me that the treatment doesn't really help them. And that's, I think, the job order that we have to continue working on this. So what we're getting at is, this is just one way.
Sorry
Yeah.
to interrupt you. You have
Yes. So this is just one way to compensate this system. Another way of doing this is to modulate the genes that regulate this pathway. So far, we identified one particular gene circuit, and I haven't been able to, or we haven't been able to mention this to the general patient community. And that is for this particular consideration. That is, the x-axis is the dose of the treatment, y-axis is the effect of the treatment. And you always have two curves. One is the efficacy of the benefit, and the other one is the safety curve. The difference between these two curves is the therapeutic range. If we do not know any of this information, we're concerned that patients might experience, issues. Either the treatment doesn't help them, or they might have side effect. So we're beginning to test the treatments that we identified in mouse model. And I'm happy to report that at least for one of the treatments, the animal model, the mice model in this case, if we knock out that particular gene, the mouse would show fatigue and perhaps more importantly, PM. So the second time the mouse would crash. And if we add back this molecule, the mouse stop having PM. So that's a really exciting, at least to me, early sign of this drug. But still, there, you can see here, there's a lot more work that need to be done. With that, I just want to thank everybody who's involved in these projects that I described, and especially patient researchers that I had the opportunity to work with for the past few years, and the more than 5,000 patients who helped us in this study. Thank you.